Hello, everyone, and welcome to today's webinar. Today, the AC Forum is presenting a webinar on DOACs and kidney dysfunction, and we have the honor of having our presenter be Renato Lopes. I am one of your moderators, Arthur Allen, and we have also bringing back Tracy Minichiello. Next slide, please. So Renato Lopes, former AC Forum board member, current member of the advisory council, and a well-established researcher. You know, Renato has been involved in some of the most groundbreaking, meaningful literature in this field and others, with, you know, either leading or be involved in studies like the Aristotle trial, Augustus, the River trial, Action, Michelle. It goes on and on and on, and we're honored to have Renato here to talk about today's topic and a paper that he was involved in called Combine AF. I'm Arthur Allen, clinical pharmacist, anticoagulation program manager at the VA hospital in Salt Lake City, and Tracy Minichiello, bringing her back to the webinar team. As they said in Godfather, she tries to get out, but we keep pulling her back in. So welcome, Tracy. I look forward to this discussion. Next slide. And at this point, I'm going to turn it over to our presenter, Renato Lopes.
Thank you, Arthur, and great to have you. Great to be here again with all, and with Tracy again, and with Liz and the whole AC Forum gang, which I had the pleasure to work with for many years, and be part of this again webinar, which is a very important topic, where we have made some good progress, I would say, in the last years, but I think we still have a few ways to go. So we're going to be talking about kidney disease and the use of oral anticoagulants. Mention a recent study that we published based on the Combine AF, which I think further clarifies some of the important issues that we see in clinical practice. These are my conflict of interests. So let's just start by remembering that we have good news in the last 12 to 14 years, since we know that warfarin is highly effective for stroke prevention in atrial fibrillation, but we finally now can do better. And we can do better because of these 4 new drugs. They're not that new anymore, but there are 4 new options compared to warfarin, 2 different classes, a direct thrombin inhibitor, dabigatran, and 3 factor Xa inhibitors, rivaroxaban, apixaban, and edoxaban. And despite the fact that there are similarities among those agents, there are important differences as well. And I'm highlighting here the renal, since the topic of the talk is kidney disease, the renal elimination rate varies significantly among the DOACs. As you can see, the dabigatran is 80% renal eliminated, rivaroxaban and apixaban about 30% or so, and edoxaban about 30%, and that's important to keep in mind. And the reason things are changing is because of these 4 really pivotal trials. These are really the 4 trials that led to the approval of these agents in clinical practice. But importantly, these trials include a large number of patients, 18,000 people, 14,000 patients, 21,000 patients. But all of them basically excluded patients with creatinine clearance less than 30, or in Aristotle, we actually went a little bit lower, and we included patients up to 25, until 25 mLs per minute of creatinine clearance. So again, all of these trials really did not address the final stage, particularly the hemodialysis patients, and we're going to touch on that in a second. But if we put this in a timeline, until 12 years ago or so, or 14 years ago, basically everything we knew about atrial fibrillation and stroke prevention was coming from 2,900 patients from the old trials in the late 80s, early 90s, including 2,900 patients, and that was it. Everything we knew about AFib, stroke prevention, was the warfarin placebo-controlled trials. And in the last years, we can appreciate the evolution and explosion of data, with now more than 71,000 patients enrolled in these 4 pivotal trials that led to the approval of these drugs. But more importantly, I believe that these trials did more than just really bringing 4 new agents to the market, which is always good to have better options and more options to treat our patients. But what these trials did was really identifying also gaps in other clinical scenarios. And then we were able to do a lot of trials and start closing those gaps and understanding more about really anticoagulating patients in different clinical scenarios that we thought we knew. And then we made tremendous progress as well. So that's why I really think that these trials really are allowing us to rewrite these chapters in the medicines book, because we learn more about VTE, we learn more about cardioversion, we learn more about cancer associated with VTE events, we learn more about renal impairment patients. We are learning more about subclinical atrial fibrillation, about combining antithrombotic therapies, anticoagulants with antiplatelet agents. So again, because of these trials, we identify several gaps and start doing trials to address those gaps that were not necessarily studied in the pivotal trials. So having said that, what we've done recently is all the leaders of these 4 pivotal trials got together in a really collaborative initiative called Combine AF. And we combine our databases to really try to have patient-level data and provide the most accurate treatment effect from NOACs for NOACs versus warfarin, as well as having stronger and more robust subgroup analysis in a patient-level data to be able to provide the best point estimates for each given treatment effect for efficacy and safety in different subgroups. And this was presented 3 years ago at the ESC, and we found that yes, NOACs are better than warfarin with a 20% relative risk reduction in the risk of stroke and systemic embolism, even with an 11% relative risk reduction in the risk of death, all-cause death, 14% relative risk reduction in major bleeding, and the main importance aspect of NOACs really with a 55% relative risk reduction in intracranial hemorrhage, which to me is one of the most important findings and characteristic of the NOACs that justify our main use in clinical practice. As I always say, there is no free lunch. When we look at NOACs as a class, the 4 combined, the 4 drugs combined, and look at GI bleeding, we have an increase in GI bleeding with NOACs, particularly because of the way they are metabolized to the GI tract, whereas warfarin is metabolized to the liver. Although there are differences among the NOACs for the GI bleeding story, we can come back to that at the end. But overall, it's still a positive net clinical benefit. When we look at stroke, systemic embolism, major bleeding, and all-cause death, we still have a favorable outcome favoring NOACs compared to warfarin. And that's why, if we look at the most recent AFib guidelines, now we have NOACs as a class 1A recommendation, so over warfarin. So there is no question that it should be a preferred agent over warfarin, class 1, level of evidence A, based on all these robust data that we have. But this is really what we try to do. We try to avoid stroke. We try to avoid ischemic stroke. We try to avoid the ischemic complication, and at the same time, not increasing too much the risk of bleeding. And our job in every clinical patient, in every clinical scenario, is really to find what I've been calling for the last 10 years, the antithrombotic sweet spot. And the antithrombotic sweet spot basically means that I have to look at patient characteristics, clinical context, and choose the right drug at the right dose for the right duration that will give me the greatest reduction in ischemic events at a minimal cost of bleeding. The bleeding is never going to be zero, but if I can minimize the bleeding and preserve the efficacy, and we're going to talk about this, that's the key, to preserve the efficacy and minimize bleeding to find the sweet spot. It's not about bleeding only. It's not about just minimizing bleeding, because if that was the case, I could just give water to patients. And if I give water, they don't bleed, but then the ischemic events are going to be very high, and I'm not going to be preserving the efficacy. So the key here is to minimize bleeding while we preserve the efficacy to give the best net clinical benefit to our patients. So when we talk about renal disease, then it's a very heterogeneous group of patients. We can see the first patient, Helen, 84-year-old female, CHA2DS 4, creatinine of 2, creatinine clearance of 25, and those patients we have included in the trials. And we had tremendous progress in using DOACs in this patient population, and we're going to review some of this data. But we also, when we talk about renal impairment or renal disease, we still have also a different group of patients, which is illustrated by the second figure in the slide, which is David, 65 years of age, CHA2DS of 3, hypertension, diabetes, and on hemodialysis 3 times a week for the last 4 years. And this is a population that we haven't done as much as a progress as in the other group of patients as Mrs. Helen above. So we're going to talk a little bit about those 2 different scenarios. They are both renal impairment patients, but with different strength of data around those types of disease, of spectrum of the renal disease, and it's important to put that in context. So again, as I mentioned before, the elimination of the anticoagulants, of the DOACs, can vary tremendously. And all of the trials excluded those patients with creatinine clearance less than 30 or 25 in Aristotle. And because of that, we had regimens to adjust the dose. Regimens that were used in the trials to adjust the dose when there was or there were dose reduction criteria. And each drug has their own dose regimen, their own dose adjustment criteria. Some of them follow the package insert of the approval, follow what the trials did. Some of them did not, and we're going to talk about that maybe at the end. But it's important to understand each of the agents and their dose reduction criteria. We learn a lot about those in this field. And this is really interesting because 2 of the trials, as you remember, the RELY trial and the ENGAGE trial, they had an arm of higher dose or standard dose, so dabigatran 150, and a lower dose, 110, where patients were randomized to warfarin, dabi 150, dabi 110. So they had a lower dose. And the ENGAGE trial also had an arm of standard dose edoxaban 60 milligrams and a lower dose edoxaban of 30 milligrams. And with that, it's very interesting because we can look at the lower dose results. And if we look at dabigatran and edoxaban lower doses, we can appreciate a tremendous benefit in bleeding, as we can see in this figure with lower hemorrhagic stroke and lower intracranial hemorrhage. However, when we look at ischemic stroke and when we look at myocardial infarction, we start seeing on the right increase in ischemic events, because every time we lower the doses, we are getting closer to water. And if we're getting closer to water, we are increasing the risk of ischemic stroke. But on the other hand, in the Aristotle trial, Rocket trial, we didn't have an arm of low dose. We actually adjusted the dose when patients had criteria to do so. In Aristotle, we used 2 out of 3 dose reduction criteria. And in Rocket, we use renal function alone, mainly as the dose reduction criteria. And we can appreciate that when we do that, we can see in yellow that when we adjust the dose of apixaban and rivaroxaban, we actually have less bleeding, but we also have less stroke. So the efficacy is preserved. However, when we look at RELY and ENGAGE, and we look at the lower doses regimens, in yellow, on the top, we have less bleeding, but we start having higher rates of strokes. So again, really learning that lower the dose might not be the thing to do in practice, but adjusting the dose seems to be the right thing to do. And of course, we also start having subgroup analysis where we can appreciate the area and the exposure with dabigatran increases as renal function goes down. And that's why we can see that as renal function goes down, we can see on the bottom right as an example, when creatinine clearance arrives close to 50 or below, we have a switch on the curves where we start having higher rates of bleeding with dabigatran compared to warfarin. So renal function goes down, safety goes down with dabigatran, primarily because it is 80% eliminated by the kidney. So if your kidney is shutting down, you have more drug circulating, and therefore you might have higher rates of bleeding. With rivaroxaban, we did not find any interaction based on renal function or renal impairment and the treatment effect of rivaroxaban versus warfarin. So rivaroxaban was not inferior to warfarin in patients with normal renal function, but also in patients with impaired renal function. In the Aristotle trial, very interesting, on the left, we did not find an interaction for efficacy, but we did find an interaction for safety, but in a very interesting direction, which is the opposite that we saw with dabigatran. With dabigatran, as I just showed, renal function goes down, bleeding went up with dabigatran. Now, as we can see on the right, with apixaban, as renal function goes down, the safety of apixaban went up. So the apixaban was even safer than warfarin in patients with renal impairment compared to patients with normal renal function. And this was had a significant interaction, really showing heterogeneity in the treatment effect, in a way that, yes, the benefit of bleeding, the safety is present in patients with renal function, with normal renal function, but as the renal functions deteriorated, the safety of apixaban becomes even greater. This was the true and the case for different ways of measuring renal function. So using the Kirchhoff GOLD formula, or using the CKD-AP formula, or even using cystatin C, we've seen a very consistent results for the safety of apixaban across the spectrum of different levels of renal function. And finally, with edoxaban, we also found this borderline interaction showing that as the renal function went down, the efficacy of edoxaban actually increases. In other words, as renal function went down, edoxaban seemed to be even better in stroke prevention compared to warfarin. And this was, again, with a borderline interaction showing some really difference between patients with normal renal function, where basically we didn't have a lot of difference, but as the renal function started to go down, we start having higher efficacy of edoxaban compared to warfarin. So very interesting results, also demonstrating some level of heterogeneity in the treatment effect of edoxaban versus warfarin for efficacy endpoints, so for stroke and systemic embolism, according to different levels of renal function. For bleeding, there was no interaction. Edoxaban was safer than warfarin in patients with normal renal function, but also in patients with impaired renal function. So again, really completing the subgroup analysis of renal impairment patients of all the major pivotal trials. And more recently, what we did based on the combined AF data that I explained to you all, we published this paper in Circulation, really looking at the combined patient level data using all the pivotal AFib trials to try to look in more details around the efficacy, safety of DOACs versus warfarin, but also trying to look at this issue of low dose versus the standard dose, and to see if there was any significant difference. So the first thing that we found in this paper is what we already know, that as renal function goes down, as you can see, based on the creatinine clearance level, from the right to the left, renal function goes down, creatinine clearance goes down, the rates of major bleeding, the rates of intracranial hemorrhage, the rates of stroke, and the rates of death goes up. So this is well known. Renal function is a marker, or renal impairment is a marker of worse outcomes. Some scores even include renal impairment and renal function as one of the variables to predict outcomes, because we know that the lower is the creatinine clearance, the higher is going to be clinical events, both bleeding events and stroke events. Then we look at the treatment effect overall of NOACs versus warfarin, and we can, according to different levels of renal function, as you can see on the x-axis is the renal function in creatinine clearance going from the highest on the left to the lower on the right. And on the y-axis is basically the hazard ratio. So everything that is above 1 favors warfarin, everything that is below 1 favors the NOACs. And we can see that for bleeding, we haven't seen a lot of difference according to renal function. But for intracranial hemorrhage, clearly a borderline trend or a borderline interaction with an important trend that as renal function went down, the safety of NOACs in terms of intracranial hemorrhage improved or increased. Same we saw on the left, bottom left, for stroke and systemic embolism, and this we found a significant interaction. So again, as renal function went down, the DOACs treatment effect versus warfarin became even more efficacious compared to warfarin, as we can appreciate, because clearly the hazard ratio went below 1, and in the higher levels of renal function, the hazard ratio was around 1. So basically, renal function goes down, NOACs became more efficacious with a higher efficacy in stroke and systemic embolism prevention compared to warfarin. So very interesting results. And then again, for mortality, we found a borderline interaction as well, with an important trend showing the same direction that we showed for intracranial hemorrhage and for stroke, that as renal function goes down, NOACs as a class are associated with lower risk of death, but particularly in the lower rates of creatinine clearance. So very interesting findings demonstrating overall that NOACs seems to be, in general, a better drug than warfarin, particularly as renal function goes down. And then we also compare the standard dose versus the low dose. And here I put the definition. So standard dose are basically the doses that we use in Rocket and in Aristotle for Riva and apixaban, including the protocol guided adjusted dose. Because we know that if you adjust it according to the protocol, those are considered standard dose. And also we use Rely 150 milligrams or with dabigatran 150 milligrams, or edoxaban based on the Engage trial, the 60 milligrams or 30 when there was an appropriate adjustment for that. So those were considered the standard doses, which are really the standard doses that we use in practice. 20 of Riva, 5 twice daily of apixaban, 150 of dabi, or 60 of edoxaban, with the appropriate adjustment when required. For the lower doses, we consider that really the 110 milligrams of dabigatran based on the Rely trial, or the 30 milligrams in the edoxaban trial, and also when that dose require an adjustment to 15 milligrams, which is half of the 30 milligrams, in that arm of the Engage trial, we also consider all of those lower doses. So again, we try to compare now standard doses versus lower doses. And what did we see here? Let's focus on the yellow bar, which basically is lower doses versus standard doses. And we can appreciate that as renal function goes down from the left to the right for major bleeding, basically we found that there was no difference in terms of major bleeding between lower dose and standard dose. As a matter of fact, the hazard ratio get closer. The hazard ratio in the yellow line get closer to 1 as we lower the creatinine clearance level. For intracranial hemorrhage, we can appreciate that as renal function goes down, again, not much difference in terms of the intracranial hemorrhage between lower dose and standard dose. So really interesting, showing that this perception that lowering the dose will reduce bleeding or intracranial hemorrhage compared to the standard dose actually did not show to be true in the lower levels of creatinine clearance. So in patients with impairment of creatinine of renal function. For stroke, as you can appreciate, actually, as renal function goes down, we can appreciate that now the yellow curve actually goes above 1, which means that we have now increase in ischemic stroke with the lower doses. So on the left, on the bottom left, as renal function goes down, the hazard ratio for the lower dose versus standard dose start getting above 1, meaning higher rates of ischemic stroke and systemic embolism with the lower dose compared to the standard dose in the lower level of renal function. And same pattern we saw for mortality. So those are really interesting results because it's demonstrating that, yes, lower dose and standard dose are both safe for major bleeding and for intracranial hemorrhage, irrespective of the renal function. However, for efficacy, for stroke and for death, as renal function goes down, what happens is that the lower doses start having more events, higher rates of events compared to the standard dose. So again, really, really important message. And the conclusion is that standard dose are safer and more effective than warfarin down to a creatinine clearance of 25 mL per minute. We showed that before. So DOACs in the standard dose are better than warfarin, safer and more effective. But the lower dose that we showed did not significantly lower the incidence of bleeding and intracranial hemorrhage compared to standard dose. However, they were associated with higher rates of systemic embolism and death. So it's really the opposite that we think. When we are lowering the dose, we are afraid of bleeding, we want to reduce bleeding, but we show that actually we didn't reduce bleeding. As a matter of fact, we increased strokes and death that could have been prevented if we had used the standard dose. So basically these findings in the best data we have out there, more than 71,000 patients, patient level, supporting the standard dose over warfarin for patients with kidney disease, and supporting the concept that we should not lower the dose, but we should adjust the dose when it's indicated. And this is this is also confirmed based on this large registry on atrial fibrillation that we did in the US, Orbit-AF, where we show that every time you use an inappropriate dose, lower dose or overdose, you're gonna have worse clinical outcomes. You're gonna have higher rates of bleeding, higher rates of death, higher rates of hospitalizations, and higher rates of strokes. So basically confirming what we just showed in the combined AF study. The Orbit-AF study was done many years ago, as you can see, about 7 years ago, but already showed at that time that using lower doses was not something that we want to do for our patients. And then finally, now switching to the dialysis patients is a whole different story, because we are talking about a patient that going to have a prothrombotic event even greater. There is some level of coagulopathy involved with dialysis patients. And we show that it's being shown many times that these hemodialysis patients are at higher rates for AFib. They have AFib more often. Patients with AFib and hemodialysis, they have a higher rate mortality. So again, AFib is a marker of bad outcomes. AFib is a marker of worse outcomes in different clinical scenarios and in dialysis as well. So this has been shown many times before. But then when we look at different levels of renal function on the left for stroke and on the safety for bleeding on the right, we can appreciate that, yes, warfarin has this benefit in patients in reducing stroke, as we showed, in patients with normal renal function. But as the renal function goes down, we can appreciate that the efficacy seems to go away. Basically, no big difference between no anticoagulation and anticoagulation with warfarin for efficacy in patients with creatinine clearance or less than 15 mL per minute. So again, the efficacy that is well known of warfarin seems to go away in the very end stage of renal disease. And on the right, we can appreciate that in the same population, that is exactly where the bleeding becomes to be even greater. So we have much more, exponentially more bleeding on renal impairment dialysis patients. So again, efficacy seems to go away and bleeding goes up, so we don't know what to do. And if you look at the meta-analysis, first of all, the studies are not well, they are not robust, they are not randomized. And if we try to look at this meta-analysis, basically, we show no difference between anticoagulating versus not anticoagulating patients on dialysis in terms of preventing stroke. So we don't know what to do. It's the perfect equipoise. So what we learned is that CKD not on dialysis, we have enough data as I demonstrated to use the DOACs for efficacy, depending on the level of renal impairment. However, for dialysis, we have very few trials now, conflicting results in terms of efficacy, mainly showing no efficacy, low treatment persistence, very difficult to control warfarin in this population, increased risk of bleeding and vascular complication because of the vitamin K cycle, and also very low use of VKA in many studies. So we just don't know what to do. However, one of the DOACs is approved in the US, as you all know, apixaban for dialysis patients, and we start having some real-world data to evaluate how are these patients doing. And when we look at this data, we can see that apparently no big difference between apixaban and warfarin for stroke, some benefit for bleeding in the dialysis population, some benefit for GI bleeding, and interestingly, very interestingly, some benefit in all-cause mortality favoring apixaban compared to warfarin. Again, not randomized data, so all caution has to be given when interpreting this type of results. And when we try to compare the doses, is really favoring the dose of 5 milligrams of apixaban to be used in this population, because again, we need 2 out of 3 criteria, and dialysis will be only 1 criteria, which is the renal impairment, but not if I don't have the age criteria, if I don't have the weight criteria, 5 milligrams is really the dose to be used, and the benefits in this study was really shown to be there and preserved with the 5 milligrams and not with the 2.5 milligrams. Based on this, the 2019 ACC/AHRS guidelines recommend as an alternative for patients with creatinine clearance less than 15 to use dialysis or in dialysis to use warfarin or apixaban. However, the European guidelines basically say that for those patients less than 15 or hemodialysis, we just don't know what to do. And therefore, we need to individualize these patients. Well, this is bad on one hand because we don't know what to do, but it's good because it's the perfect equipoise to do a trial in this field. And we try to do this trial, Renal AF, basically looking at patients on hemodialysis, CHA2DS2 or greater, atrial fibrillation, and randomizing patients to apixaban or warfarin, and looking at ISTA bleeding, major and clinically relevant non-major bleeding as the primary endpoint. Unfortunately, the trial was stopped prematurely. We planned to randomize around 760 patients, and we couldn't finish the trial as planned. And basically, the trial became more of an exploratory trial than anything else. And we can appreciate that within these limitations, there was apparently no difference between apixaban and warfarin in terms of ISTH, major or clinically relevant non-major bleeding. Again, we tried to do the trial, it became exploratory, and I believe we still don't have the answer to that particular question. As a matter of fact, in my view, the perfect trial, and the good news that we might be launching this trial next year, the perfect trial to me is a trial that has 3 arms. We have warfarin in patients on dialysis, we have a NOAC, and we have a third arm, which is no anticoagulation. Because before deciding between apixaban or rivaroxaban or warfarin, I'm not even convinced that we need to anticoagulate patients on dialysis because the data do not support that. So to me, the first question is anticoagulation versus no anticoagulations on dialysis. And if anticoagulation shows to be beneficial in a randomized setting, which we don't have so far compared to placebo, then the second question is a NOAC better, safer than warfarin? So to me, it's a two-step question. And that's why I think we need to have a 3-arm trial. And we are working super hard to try to bring this trial to be started and hopefully have this answer in the next few years that we still don't have. So to try to keep my time and so we can have time for discussion. So in conclusion, I think we are in a new era for anticoagulation in atrial fibrillation and in other clinical scenarios as well. I think we need to embrace this era because patients with AFib and other clinical settings using the traditional therapies, they continue to have events. And now we have better drugs. They are safer, or they are at least as safe as warfarin, if not safer. They are at least as effective as warfarin, if not more, but have important advantage over warfarin, particularly the lower rates of intracranial hemorrhage. In patients with CKD, especially with hemodialysis, we know that CKD is a marker, is a predictor of both thrombotic events, but also bleeding events. And again, there are two different groups of patients. The patients with AFib and CKD, but not on dialysis. I think I showed that anticoagulation is very beneficial. NOAC seems to be better than warfarin. The issue is getting the dosing right and monitoring these patients correctly. And remember, we should use the standard dose for these patients. We should not lower the dose. We should adjust the dose. Because if I lower the dose because I'm afraid of bleeding, I might be causing preventable strokes or systemic embolism events that could be prevented if I have used the right dose, the standard dose. On the other hand, on patients on end-stage renal disease, on dialysis, outcomes are terrible. These patients are high risk for stroke, high risk for death, high risk for bleeding. The benefits of anticoagulations are still not established, as I mentioned, but the bleeding risk is real. The vascular calcification risk is real, and we need to be, at least with warfarin, and we need to be careful with that. And we desperately need randomized trial to guide the practice in this patient population. And we hopefully will get this trial started early next year and bring an important question to guide clinical practice for this high-risk group of patients. So with that, I'll finish here. Thank you so much for being here, and I'll pass it over again to Art.
Well, Renato, thank you so much. Folks, we have almost 500 people on this webinar, and I hope that you appreciate the absolute knowledge, truth bomb that are being dropped here by Renato. As usual, you know, your work speaks to those issues that we in the trenches deal with on a daily basis, and you answer and address the questions as cleanly as any researcher and scientist I've ever seen. So thank you so much for this work. Just to, you know, to summarize some of the truths that I think that you dropped on us here. One is, you know, going back to the pivotal trials, understanding the difference between the dabigatran and edoxaban trials, which use randomization to assign patients to treatment, versus, you know, apixaban and rivaroxaban trials, which actually dose adjusted based on criteria, be it creatinine clearance or 2 out of 3 criteria, as in the case of apixaban. That is extremely important, and that does not jump out at you. And if you just get your dosing information from, you know, the prescribing information of these agents. You know, other truth bombs that I think that you dropped are, we really don't know that there is benefit in dialysis patients of anticoagulation therapy. That's certainly their net benefit. That data is not new. And I think that if you really read the guidelines carefully, when they get to end-stage renal disease dialysis patients, what they say is it may be raisable to. They take a much different approach in their language about recommending about treatment of these patients. So I think it's extremely important that we understand it's not necessarily a question about warfarin versus something else. It's a question of should we? And so thank you so much for that. To that end, let me kick off with what a lot of folks want to know about. Should we be treating patients who have end-stage renal disease but are not on dialysis, but very poor renal function, versus those who are on dialysis, versus different modalities of dialysis, hemodialysis versus peritoneal dialysis? Should we be treating those patients differently or thinking about them differently if we're going to anticoagulate?
Yeah, Arthur, I think that's a good question. Some of the labels globally, as you know, it brings the option of treating patients up to creatinine clearance of 15, even though this patient population was not included in the trials. And when you look at the curves, particularly of some of the DOACs, and here I mention apixaban just because it's really impressive, that interaction of safety of apixaban in the lower level of renal function. It's very unlikely that that curve will change from 25 to 15. So I think it's reasonable, and those patients are high risk, and they are not on dialysis, which is a different ball game. You have heparin doing dialysis, you have the machine, you have a bunch of other things going on. So I think it's reasonable to anticoagulate those patients. Again, in some countries, the label goes up to 15 to be used, DOACs, and I think it's reasonable without having really the data 100% to confirm that benefit. But when you look at the trends of the curves, for the dialysis, I think it's an open question. Regardless, the PD, the peritoneal dialysis then is even worse, because then we don't have any data whatsoever. And I still don't think that it's clear if we should anticoagulate those patients or not. Those are patients that are tricky, so I try to individualize them in clinical practice. I look at how high is the CHA2DS2-VASc, how high is the bleeding score, the history of these patients, if they bled in the past, if they have coronary disease, because sometimes if the stroke risk is not too high and these patients have strong atherosclerosis, sometimes using dual antiplatelet therapy will have some protection in stroke, based on the active program in the past that we've seen that when you add clopidogrel to aspirin, you add some protection to stroke. And might be an option in some patient population, not everyone, in some patient population. In some patients, you might decide to not anticoagulate anyone. In the US, we have the ability to use apixaban, which I think is a better option overall than warfarin. Not because better option, because we have the data, just because warfarin seems to be terrible for dialysis patients. And we also have other options like occluding the left appendage, left atrial appendage. It's an option that we can also use, although again, without the definitive data to support that. But it is a technique to exclude the left atrial appendage, where 90% of the thrombus stay when causing stroke. So those are options that I don't think we have a final decision answer to all these patients. We have several options with weak data. And what I try to do in these patients is really talk to patients, talk to the family, individualize the entire patient scenario, and try to come up with the best decision for that particular patient. But we don't have I don't think it's a one size fits all for this population.
Excellent. Yeah, I think for the audience here that the real message is, if you're worried about using a DOAC in a patient based on their renal function or dialysis, your real question should start at being worried about anticoagulating at all. If you're going to anticoagulate, then the trends that you're showing would suggest that DOACs are probably the preferred agent in that population. And then also, let's not forget about left atrial appendage exclusion, as you mentioned. Tracy, what question do you have for us?
Well, Professor, that was an amazing whirlwind tour of this area, and I thank you so much for this. I'm glad it's recorded. I think we'll all need to listen to it about 20 times. So just to dovetail on the question about dialysis and anticoagulation, or for patients with significant renal dysfunction, it sounds like you're preferring apixaban if you're going to do it with a creatinine clearance less than 15 or 20, and apixaban if you're going to do it in a patient on dialysis, because it looks like the data, there's probably some net clinical harm with warfarin. What dose of apixaban would you be using in a dialysis patient if the indication is atrial fibrillation?
So Tracy, thanks. Always nice to be with you again in these webinars. And I think that's a great question. And in the Renal AF study, based on the totality of the data that we had, and based on the real world type of registry or type of data, it's a combination of real world evidence and registries that are going on in the US. It seems, with all the limitations of this data, understanding that we don't have the final answer because we don't have the final randomized well-powered study, it seems that 5 milligrams seems to be the most appropriate dose to be used, because in the dose reduction criteria, renal function is just one of the criteria, and we don't have the second one. And when you look, Tracy, and I always like to remember people about this, when you look at the spectrum of doses of apixaban, actually, let me step back. When you look at the spectrum of doses of rivaroxaban that were tested in different preclinical work and also in the early phase studies, 20 milligrams is already in the higher end of the dose of rivaroxaban. Edoxaban 60 is in the higher end of a dose of edoxaban. 150 of dabigatran is in the higher end of dabigatran. But 5 milligrams of apixaban twice daily is already in the lower end of the doses that were tested. So, which means that you have, and maybe that's part of why apixaban seems to be so safe across the board, because you're already in the lower end of the spectrum of doses of apixaban that could have been chosen to do the programs or to do the trials. So when you then cut this to half, you're going too low. You're going too really close to water. And that's why you need extra things to justify adjusting the dose. And these extra things is really 2 or 3 criteria and not just one. We actually published a study on Aristotle looking at, is there any beneficial of adjusting the dose based on only one criteria? And we published this in JAMA Cardiology. This was led by John Alexander from our group. And we didn't show that. So there was no benefit in efficacy or safety by adjusting the dose based on one criteria, as opposed to following what we did in the trial, 2 out of 3. You might say, well, how did you do that before the trial? Actually, we didn't know that it's going to work. We used the data that we had, we did some simulations, and we felt that this was the right thing to do. But what really proved that work was after the fact, after the study was done, and we were very happy to see that that seemed to work for most patients.
So just to clarify, just to summarize, 2 out of 3, stick to the 2 out of 3 criteria, no matter where you are on the spectrum of your renal function, if you decide, in fact, to use anticoagulation for atrial fibrillation. We haven't talked about VTE yet. Cool. And you haven't mentioned this, but any role for levels, or just stick with your guidance, your 2 out of 3?
Yeah, so that's a great question. And basically, I always like to mention that when we were using warfarin for decades, we always wanted, and we always say, I wish I had something that I can use without measuring, like without having to do the INRs, without having to measure. I wish I can have something to do without having to measure any levels of anticoagulation. Then we do 4 trials. We prove that we have 4 drugs that can be used. And what is everybody saying? How can I measure? So that's just to illustrate that we always want what we don't have. And I think what we learned about measuring the levels is that it might be beneficial in a few scenarios, not routinely, I would say, but in extreme body weights, in maybe a few patients where the renal impairment might be difficult and you might be in doubt between efficacy and safety outcomes or risks. In a few patients post-surgery, post-gastrectomy, for example, that you are in doubt about the absorption. So I think there are a limited role for doing that in selected situations. And we learned to do that the trough seems to be more important than the peak, which is a little bit counterintuitive. But that's how I think that we should use with a lot of caution in a few clinical scenarios, and most of the time looking at the trough more than the peak as predictor of bleeding and risk of stroke.
And Arthur, can I ask you, are you doing troughs in your dialysis patients who are on apixaban for atrial fibrillation?
I still hold my record of having never ordered a DOAC level. I'm hanging on to that one. I think I have access to them. If it's a send out, it might take me a week to get one back, but I have never ordered one. And I know that you folks have access to them at your site, and you have done some of these.
And
very
Tracy,
slow turnaround time.
Yeah, one more comment. The Renal AF, we have some data that we look at PK and PD, and we have the 2.5 milligrams, the 5 milligrams twice daily. And you know, the overlap is so big among these ranges that is very difficult to come up with a reasonable indication or a reasonable result or a reasonable interpretation on how to do it. So if you want to go even further, maybe a future trial, once you show that there is a benefit in anticoagulating, then if you're testing apixaban, it might be worthwhile testing 5 and 2.5. But looking at clinical outcomes more than just PK and PD data, because that's really what matters. Looking at the clinical outcomes, and similar to what we did in the VT arena for the Amplify extension study, where we tested 5, 2.5, and placebo, and we showed that 2.5 and 5 were equally efficacious, and 2.5 was a little bit safer. So it gives you the first question, yes, we should do it, the extension, and if we do it, you should do it the lower dose. So I think that's the type of study that would be nice to try to define which dose to use in dialysis, much more than just the ranges of PK and PD, because the data is not so clear.
Thank you.
So folks listening, let me drop the two truisms that were just delivered in that little exchange. Number one, if you're dose reducing DOACs outside of the recommendation based on criteria, then you're treating yourself and not the patient. That was truism number one. And number two, we begged for drugs to replace warfarin for 50 years, and as soon as we got them, we tried to turn them into warfarin. That's what was just said there. And these drugs are not narrow therapeutic window drugs. I think that we forget that. Warfarin's a narrow therapeutic window drug, and we're so accustomed to that. These drugs have wide ranges of efficacy, so they're just not narrow therapeutic window drugs. Let me talk a little bit, if I could, Renato, about dabigatran. So dabigatran in some large health systems is the preferred agent, and I believe that this is going to become even more meaningful as it becomes the first generic available on the shelf. The prescribing information with regard to atrial fibrillation and renal dosing uses a 75 milligram dose, and it recommends that when patients have a creatinine clearance of 15 to 30, which is a population excluded from the trials, and in the setting of certain drug-drug interactions, which the study was not done that way. The only trial that dose adjusted or based on a drug-drug interaction was the edoxaban trial. And so what are your thoughts about the 75 milligram dosing option, which to my knowledge has still not been clinically proven in the literature?
Yeah, Arthur, I think that's a great question. And we all were very surprised when we've seen the approval of 75 milligrams dose, when we had a trial with 18,000 patients, being 6,000 of them being randomized to the 110 milligrams, which demonstrated 110 milligrams to be as efficacious as warfarin, which means very good for stroke prevention, because warfarin is extremely good to prevent stroke, but safer than warfarin. And I think trying to understand this approval by the FDA is probably related to the fact that we had another dose, which was 150 milligrams, that was more efficacious, was superior to warfarin in preventing strokes. And I think the FDA didn't want to have the option of 110 to being safer for people to go to that dose and forget to give the most efficacious dose, which is 150 milligrams. Because remember, in AFib, the main goal is to prevent strokes and not to prevent bleeding. Bleeding is part of the equation, but the main goal is to prevent stroke. So in a way to avoid people just going to the 110 because of safety and not giving the best efficacy dose, which is 150, that's why they use some PK/PD data and came up with the 75 milligrams. That's what I think is the explanation for that. Not that it justifies in my view, because when you have a trial with clinical data with 6,000 patients using 110, that would have been my preferred option to get the approval of the dose that was tested clinically in a well-conducted trial with very good clinical data to support clinical practice.
Excellent. Thank you for that.
Okay, another question. Now, this is a burning question. We need an entire webinar for this, but what we have is about 60 seconds. So I'm going to just ask you, how do you manage these patients? So everybody wants to know what you do with a patient with a DVT or PE that has very, very compromised renal function or end-stage renal disease. And are we using DOACs? If we're using them, how are we dosing them? Or are you favoring warfarin and standard unfractionated heparin, et cetera? So I know that's a loaded question, but it's a rapid fire one.
Yeah, Tracy. So as a you're right, we could do a webinar on this topic because there are so many nuances and so many important aspects. But overall, I would think I would do what the trials did, and the trials did not have an adjustment criteria for these VTE treatments, and particularly I would use the standard dose to treat these patients, particularly with those drugs like Riva and apixaban, where you don't need the initial heparin up front for a few days as you need for Dabi and for edoxaban per protocol. There are good options, but honestly, in my practice, I'm using right away DOACs without having to give the heparin as an initial part of the treatment with the standard doses.
Okay, so if creatinine clearance less than 15, they'll get apixaban 10 BID and then 5 milligrams BID after that first 7 days.
Well,
an acute VTE.
Well, for this extreme of patients, I think we have also even less data, I would say, than with AFib. Because with AFib, at least we have some real-world evidence with some registry. We have one trial or a few trials, small trials that can give us some data. But for the VTE one, I actually think that using heparin for those patients might be a good option, at least in the beginning, because the risk of recurrence is in the very first 7-10 days. You can adjust potentially based on ways that we are familiar with to adjust, and we probably give a more consistent anticoagulation profile for this patient population, more than almost in a blinded way in using apixaban. So I said to use the DOAC overall for most of patients, but for this example that you gave, I think that it makes sense to actually use heparin, so you can measure these patients and keep them more tightly anticoagulated, at least in the first 7 to 10 days, which is the most critical piece, the most critical phase of the recurrence event.
And after that, going to apixaban after that first 7 to 10 days?
Yeah, then you can probably do the switch, because then is basically, again, now we are in a data-free zone, right? But basically then I think, again, I would avoid warfarin, because I'm convinced that warfarin for dialysis or for very low renal function is not a good option. So then I think it's reasonable to go with apixaban.
All right, Renato, thank you so much for that. Wow, for those of you that were unable to attend or that had to bail out a part of that, or even if you've already listened to it, I recommend you go back and listen. There's a lot presented at this talk. In fact, the webinars are now not only stored on the AC Forum website, but actually are there's a YouTube channel dedicated to these webinars, so you can go back and watch these at any time. I want to thank Renato for taking the time out of his busy schedule to join us and to present on this very important work. And I want to also thank my friend and colleague Tracy Minichiello for joining us in this discussion, helping to co-moderate this discussion. Next slide. Next webinar topic will be in July 25th, outpatient anticoagulation stewardship, focusing on DOAC management models. So register for that and don't miss it. And next slide. And again, as mentioned, the webinars are archived on our YouTube channel. I recommend checking that out. And also, if you missed the April conference and that we had in San Francisco, it's an excellent conference. You can still actually register for that and have access to recorded content. Information is on your screen there. And rolling back out AC Forum boot camps. The next boot camp will again be virtual, and there's information on your screen. Recommend checking out the boot camps, especially for new staff, perhaps, or those learners that need to get started in this field. I'd like to thank our corporate sponsors for who support this webinar series. And again, thanks to all of you for attending, and to our presenter and co-moderator, Tracy Minichiello, and to the AC Forum for putting these on. We'll let you get back to your day. Thank you so much for your time and attention.
Thanks, everyone.